الموضوع اللي انا هتكلم عليه النهارده هو فيكو ان corneal opacities. احنا طبعا في مصر عندنا a lot of cases of different grades of corneal opacities. وانا بحضر المحاضره دي اللي افتكرت فيلم الكيت كات. يعني هو ده اللي انا افتكرته، اذا ما كانش سليم النظر اللي زي حالاتي يساعد عاجز النظر اللي زيك لا مؤاخذه، يعني بقول على الدنيا سلام. فهو ده اللي افتكرته وانا بحضر البرزنتيشن دي. احنا بنقابل different يعني situations of corneal opacities. في corneal opacities you can see through it, so you can يعني operate بالregular case with more care. وفي حالات انت you have to do something different عشان to be able to proceed, particularly if you cannot do penetrating keratoplasty. فانا همشي معاكم في different scenarios. This is يعني corneal opacity, vascularization, posterior synechia, mature cataract. So you have to think, if you cannot do penetrating keratoplasty, you try to work within the central, very, very central clear area. The problem also you have to know about these corneas إن هم عندهم مشاكل في الابيثيليوم وفي الكورنيال الأوكرال surface, and usually the incisions that you make, these incisions can extend very easily. حتى الباراسنتيز زي ما هنشوف ممكن الايرس prolapse. This is hard cataract. I'm following rules, working in the area I'm seeing, and you can see there is posterior polar cataract appearing. This is still, I'm trying to keep my working area within the central clear area of the cornea. And this is what encouraged me to go on and do this case as phacoemulsification. But you have to be working in a slow motion, very careful. All the time you are thinking of what you will do if the scenario does not go as you want. And this is what's very beautiful about the way of vertical chopping. Vertical chopping, if you learn it in the regular cases, will allow you always to be able to work in a narrow pupil. Through a narrow pupil, you can always divide the nucleus, and you don't need really a very wide nucleus. Of course, this you get by gaining experience by time. So here I was successful to be following the rules of surgery, using vertical chopping to safely achieve the point where I can implant the intraocular lens. And here I prefer to use a forceps to have a more controlled implantation of the intraocular lens, and checking if the lens is placed properly in the capsular bag. Usually these patients, you discuss with them that the ideal thing to do a triple procedure, penetrating keratoplasty or DALK or DMEC according to the case, and phacoemulsification or lens extraction. But sometimes you feel that these patients can benefit. They have been living for a long time with this opacity, so you can tell them, anyway, if we fail to, we don't get the desired results, we can do penetrating keratoplasty. This is another example of how we can think to tackle such cases. This is a very dense opacity degeneration taking more than half of the cornea. So I said to the patient, we will try. As always, I tell the patient if they prefer to do combined surgery or not. And here I'm trying to bypass this opacity in my way by using a fiber optic, which you can introduce into the eye through your paracentesis, or you can just put it at the limbus, and with the internal reflection, you can see the capsule. And as you can see, we have much better visibility to be able to do a rhexis. A continuous rhexis in such cases is mandatory. Very slowly, I'm trying to extrapolate in my mind with the direction with a filled anterior chamber, following the same rules, the area which I don't really see perfectly under the corneal opacity. And I'm using this window to see what I'm doing. And as you are going to see, even during the phacoemulsification, of course, I did not do hydrodissection in such case. Even in such case, I will try always to keep my work, all the work, in the window of clear cornea. So I always rotate the nucleus and do all the maneuvers in the clear window I see. And you have to be extremely careful. Of course, this needs a lot of experience, but it is based on the rules that you learn for the basic things. So once you learn rules and you understand the settings of the machine, the technique, then you can adventure such cases. I'm not saying that we should always, everybody should do this, but I want to show that you can have solutions other than the usual ones. And some patients cannot afford a combined procedure. Of course, here is an option, there is an option of extracapsular, but still with extracapsular, you can remove the nucleus, yes, but you need a capsulotomy, and you need to wash the cortex and then to implant the lens. So it's not a complete relief even in such cases. And here the lens is implanted in the capsular bag, and I can see the edge of the capsular axis and achieved what I intended to do, is to preserve whatever is clear from the cornea, remove this lens safely, and then implant an intraocular lens and see the outcome for the patient. If many times this is enough for the patient because they used to live with this opacity. This is another example that seemed easier. Again, you can see this is corneal vascularization, superficial, central opacity, pupil dilates well. Always a dilated pupil is a blessing, but with corneal opacities. But when you get corneal opacity with narrow pupil, everything is much more difficult, particularly if it's a central opacity. So everything I thought was going to go okay, easy. You have always a problem of visibility during your capsular axis. You have to be careful. Then with a wide pupil, I said I need to do hydrodissection, so I did hydrodissection. And then doing the phaco in the regular way, deep groove, because as you can see, it's a hard lens, deep groove, and then vertical chopping. Sometimes in such cases, which usually takes longer time that you are used to, sometimes if you lose attention, you can get into problems. And this is what happened to me. But the idea is that you have, as always, you have to identify when a problem happens in the proper time, so to avoid further complications, so you can manage the complication and then try to finish as planned in the first place. You can see working in the center, the pupil is starting to come to be narrower. And you see here the iris is prolapsing. I don't try to reposit it, but the idea here that even with the regular superblade or MVR you are used to, in such corneas, sometimes they just extend with the instruments getting in. They are not very good sealed wounds. The cornea is pathologic. Here, I'm trying to remove this nuclear fragment that was disappearing. Irrigation aspiration of the epinucleus and cortex. Look here. Everything, pupil is getting narrower. I'm thinking I'm about to finish. So we start to pay proper attention. This is a part of the epinucleus, but thick. Look here. I saw that the posterior capsule is open. Behind this, there is a line you're going to see now. So it's immediately, and the good thing here, you notice, you should see that a problem happened. If I didn't see a problem happen, I would continue, and then I would have this dropped or too much vitreous coming out. I saw this opening, so I went with a cutter, behind the epinucleus into the opening in the posterior capsule to remove any vitreous prolapsing and create a space so as the posterior capsule opening that does not extend. And this movement, you can see here, this is the huge big tear, and I'm doing the sweeping movement from the periphery to the center to avoid any vitreous strands. You can see here the tear. And the pupil is getting smaller. Your first priority is to remove any vitreous. Your second priority is to evaluate the remnants of the capsule and which lens is proper to be implanted in such case. So there is a complication that happened, a posterior capsule rupture with vitreous loss, but as identified in the proper time, anterior vitrectomy was done, then opening of the sulcus by injecting viscoelastic in different points of the iris, behind the iris, to create a space to check the remnants of the anterior capsule and the posterior capsule, as well as creating the space to be ready to receive the intraocular lens you are going to implant in the sulcus in such a case. There is no way to implant in the capsular bag. So I choose to put a 3-piece lens, and carefully you should rotate it in the plane of the iris while deepening the anterior chamber. Many people are afraid to dial an intraocular lens when the posterior capsule is opened. It is not a problem. The problem is always you try to dial with a differential pressure between the vitreous and the anterior chamber with a shallow anterior chamber, then you are creating problem, and you cannot go into the plane that you want, which is in front of the remnants of the anterior posterior capsule and behind the iris. So here, in spite of the complication, the achieved result was gained by implanting the lens in place without even insulting more of the intraocular lens. This is the last scenario where I decided from the beginning, I talked to the patient, I decided I'm going to do DULC and should be careful DULC. And I'm doing a regular bubble. It was not really great, but it doesn't matter. So I dissected the cornea. I said I will not be able to do the cataract through this cornea, as well as the patient will not benefit from this cornea because actually in the center there is no clear area. So I decided to do DULC because on the slit lamp you can see that this is not reaching the endothelium. It will take some more time because this was not a perfect bubble, so I continue manual dissection in a way like Dr. Sharif said, but here all I want to do is just remove most of the stroma to be able to see the cataract I'm doing. I'm trying to convert a difficult case with corneal opacity into a regular case by removing the opacified part of the cornea, and this will show you that how is the strength of this membrane and even very few layers of the stroma against the pressure and intraocular pressure gained while we are doing phacoemulsification. So here, as you can see, this converted into completely with a well-dilated pupil, immature cataract, very well visualization. It converted the case into a very nice case to do cataract and phacoemulsification in the most regular way. And then to continue my visual rehabilitation, I will implant a new corneal graft. And this is a regular phaco. I'm just giving some time for it just to show you that this very thin layer of the cornea is really tolerable to the high pressure we use during phacoemulsification. I'll put the graft. Of course, this is the preparation. The preparation is done prior to this. لكن this زي ما الدكتور شريف قال ان احنا نستغل الفرصه نتعلم ازاي نبيل الديسمت ممبرين فور ديماك يعني في preparation for ديماك different ways. الدكتور شريف قال an excellent way. This is almost the same. The idea you have to peel it underwater, the scuba technique, and you peel it and use it if you have another case, or just train to peel to prepare a DMEC graft, and then the cornea is placed. And the good idea is to mark with the graft in before suturing. Then more or less you will get the sutures coapted properly and placed properly, And usually, if a patient is keratoconus, I will use double running. If not, and there is vascularization of the cornea, I will use interrupted sutures. So in conclusion, corneal opacity with phaco is a real challenge, that you think of what you need to do and be careful all along the procedure to reach your results. Thank you for your attention.